بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلبة المرحلة الرابعة، نكمل اليوم إن شاء الله جزء بسيط متبقي من محاضرة السكروتال ديزيز. باقي لنا موضوع التستيكولار تيومرز وموضوع صغير آخر إن شاء الله. To start with testicular tumors. Testicular tumors are one of the most common tumors in men. Actually, most of these tumors are malignant in nature. مثل ما حكينا, undescended testis or testicular maldescent predisposed to this tumor. وذكرنا في محاضرة سابقة أنه even restoration of the testis into the scrotum will not alter its malignant potential, but it allows for easier detection of the tumor when it occurs. Testicular tumors may sometimes first present with metastasis. That is, it is quiescent until it first presents with features of metastasis. Testicular tumors include a wide variety of pathological types. As you know, the testis contains a lot of cell types. So each of these cell types is liable to produce a tumor or a malignancy. In fact, the most common type of testicular tumors is the seminoma. Seminoma accounts for about 40% of all testicular tumors. And as its name implies, it is derived from the seminiferous tubules. The peak age of occurrence is in the third and fourth decade of life. The most common metastasis of this type of tumor is via lymphatics to the retroperitoneal lymph nodes. As you know, the lymphatic drainage of the testis occurs to the retroperitoneal lymph nodes. Hematogenous metastasis is uncommon. The second type is the teratoma, which accounts for about 32%, and it occurs between 20 to 35 years of age. Another tumor is a mixed variety, mixed seminoma and teratoma, and other less common tumors include the interstitial tumors, which arise from the Leydig and Sertoli cells, and lymphoma, accounting for 7%, and other tumors about 5%. Testicular tumors usually present with a lump, scrotal lump, that is usually painless. However, large lumps may cause dragging sensation or pain. A recent trauma may pay attention to the lump. يعني المريض يجي عنده ضربة خفيفة على السكروتم خلته ينتبه إلى وجود هاي lump, because as we said, it is usually painless. On examination, the affected testis is enlarged. There is a scrotal swelling, painless scrotal swelling. The testis is smooth and firm. A secondary hydrocele may be present. ومثل ما تتذكرون في الجزء الأول من المحاضرة قلنا أنه one of the types of hydrocele is the secondary hydrocele, and as we said, any scrotal or testicular pathology may give rise to secondary hydrocele. ومثل ما تتذكرون قلنا أنه in order to treat a secondary hydrocele, we have to treat the underlying cause prior to the treatment of the hydrocele, وهذا شيء ذو أهمية كبيرة وراح نذكر بعد شوية شنو هاي الأهمية. The first presentation of testicular tumor, as we said, may be with metastasis, and on examination there may be features of metastasis. So secondary metastasis in the retroperitoneal lymph nodes may be large enough to be palpable per abdomen. During abdominal examination, you may feel a mass, which is a secondary metastasis in the retroperitoneal lymph nodes. Other features of metastasis may be present, like abdominal pain, backache, or even hemoptysis due to lung metastasis. Staging of testicular tumor is according to the location or the extension of the tumor. So stage 1 is when the tumor is localized to the testis only. Stage 2, the tumor has metastasized outside to lymph nodes below the diaphragm. Stage 3, the tumor crosses to the lymph nodes that are above the diaphragm. And stage 4, pulmonary or hepatic metastasis. Investigations and management. In fact, imaging is very important in the assessment of testicular tumors. So CT scan and MRI are important in order to diagnose a testicular tumor and to detect the presence or absence of metastasis in the retroperitoneal lymph nodes and elsewhere. So number 1 is imaging. Number 2, tumor markers, which are tests made on the blood. They are used also for diagnosis and follow-up after treatment. So when you face a patient with a suspected testicular tumor, you send for imaging, CT or MRI, and you send for tumor markers in the blood. These tumor markers, when elevated, it supports the diagnosis of testicular tumor, and again they are used for the follow-up of the patient after treatment. This is regarding the diagnosis. Once you have made a diagnosis, the first step in the management is the radical inguinal orchiectomy. So we open an inguinal incision and we remove the testis with its spermatic cord completely. And this will ensure the complete removal of the tumor, which is therapeutic, and at the same time it will give a specimen for histopathologic assessment that will guide further treatment. So in this step, the radical inguinal orchiectomy, we provided both a complete management of the local tumor as well as a ready sample for histopathology to guide us for further management. After the operation, the adjuvant therapy comes. Seminomas are sensitive to adjuvant radiotherapy and cisplatin, so a combination of radiotherapy and chemotherapy, whereas teratoma is less radiosensitive. Chemotherapy may be used as adjuvant therapy. So for seminoma, you can use radiotherapy and chemotherapy, whereas for teratoma, chemotherapy is more effective. In sometimes when there is a big retroperitoneal lymph node dissection may be needed. A prognosis of the testicular tumor depends on the histological type and the presence or absence of metastasis. نقطة مهمة نركز عليها أنه we said that we explore through an inguinal incision. Never open on a suspected testicular tumor through the scrotum. And that is why in the subject of hydrocele, we said that you have to treat the underlying cause prior to treatment of the hydrocele. في هاي الحالة, when you open a testicular tumor through the scrotum or you manage a secondary hydrocele due to testicular tumor through the scrotum, you will make shifting of the lymphatic drainage from the retroperitoneal lymph node to the scrotal lymph nodes. That is, you are creating another port for metastasis. يعني بالعربي التستس يكون الليمفاتيك درينج مالتها إلى الريتروبيريتونيال lymph nodes. وإحنا من نفتح انجوينال إحنا دا نحافظ على هذا الليمفاتيك درينج ودا نسد الطريق ونشيل التيومر كاملا مع السبرماتيك كورد. إذا فتحنا through the scrotum احنا دا نخلي التيومر يعبر إلى الليمفاتيك درينج of the scrotum, which is completely different pathway. يعني احنا دا نخلق طريق إلى الميتاستاسيس. So please خلوها قاعدة عندكم أنه whenever you have a hydrocele you have to exclude an underlying testicular tumor prior to management. في كل hydrocele لازم you have to exclude testicular tumor as an underlying cause before rushing into treatment of the hydrocele. آخر موضوع هو الفورنيرز جانجرين، واللي هو فد شيء يعني الله لا يشوفكم هو في حياتكم العملية كلها. It is an acute, rapidly progressive, potentially fatal. Acute, rapidly progressive, potentially fatal, infective necrotizing fasciitis. So Foreigner's gangrene is a necrotizing fasciitis, which is acute and rapidly progressive and potentially fatal. It affects the external genitalia and the perineal and the perianal region. So it is an infective necrotizing fasciitis of the scrotum, the perineum, and the perianal region, and it may also affect the penis. Management is by extensive debridement. Remove as much dead tissue as possible. هو عبارة عن necrosis of the skin and subcutaneous tissue. ما يأثر على التشو اللي تحتم، فقط skin and subcutaneous tissue, and it result in necrosis and gangrene. راح تشوفون الصورة بعد شوية. هاي هي الصورة. It is a necrosis with subsequent gangrene that affects the skin and subcutaneous tissue of the scrotum, perineum, perianal region, and sometimes the penile skin. So management at first is by extensive debridement. As I said, remove as much dead tissue as possible. مرات احنا نضطر انه ناخذ المريض يوميا لعدة ايام الى صالة العمليات. كنا بعض المرضى يوميا بالليل ناخذهم الى صالة عمليات الطوارئ، نقص الديد تشو ويصير بينه مايجريشن، ونرجع ثاني يوم ايضا نقص الى ان نصل الى مرحلة we remove all the necrotic and gangrenous tissue to get improvement. Of course, with the extensive debridement, we have to cover the patient with a broad spectrum antibiotics and frequent dressing. With time, there will be removal of the whole necrotic tissue and subsequent improvement. مرات راح نشيل كمية من الجلد أكبر مما ممكن أنه نرجع نسده بعد ما يطيب المريض. راح نحتاج أنه نعمل سكين جرافت بمكان السكين اللي عملنا له اكسجن due to necrosis. طبعا المرض مثل ما قلنا يصيب فقط السكروتال سكين and subcutaneous tissue, and the testis is spared. ما يصير أي مشكلة بالتستس، فقط أنه it will be exposed after excision. ولهذا قلنا the patient should be covered by broad spectrum antibiotics and frequent dressing. والله لا يشوفكم هذا المرض إن شاء الله. Last subject هي other less common causes of scrotal swelling، واللي هي مدرجة مثل ما تشوفون: torsion of epididymal appendages, hematoma, hematocele, idiopathic scrotal edema, sebaceous cyst, epididymal cyst, and spermatocele. هذا كل ما يتعلق بالسكروتال and testicular abnormalities. إن شاء الله يكون الجزئين مع المحاضرة واضحين، وصلتكم المعلومة. وأنا حاضر لأي سؤال ممكن أنه توجهونه عن طريق التليجرام، أو عن طريق الجروب اللي موجود بالتليجرام، أو عن أي طريق آخر ممكن ترتقونه، حتى عن طريق صفحتي الشخصية على التليجرام أو على الواتساب. وإن شاء الله بالتوفيق، والسلام عليكم ورحمة الله وبركاته.